Hi friends, good evening. So we could not conduct the session last week because of some internet issues. So today I'm going to discuss those 20 questions which you attended in the app. So let us discuss the question one by one. This is RDX series of INICET from DocTutorials. Mrs. Rama, 40 years, female, operated for fibroid uterus by laparoscopic method, was discharged on third post-op day. See, there is a patient. See, any AIMS question, I want you to understand three. You have to put three questions. Number one, have you read this concept? This is the first question you should do when you are prepared, when you are going to answer a AIMS question. Have you read this concept? This is the first question you should know. Have you read this concept? Do you know anything about this concept? First of all, you should know what is this concept. Have you read this concept? Yes means you should proceed further. Read the question, understand what concept they are going to ask. If you have read the concept, yes, then you take the second step. Can you exclude? Can you exclude two choices? That means what? You can exclude two choices. These two cannot be the answer. Like, can you exclude two choices? Yes means then only you should attend. That is a third step, attend the question. If you are unable to exclude two choices, better mark in the review. You can decide about this question later. If you have not read this question, skip the question. Okay, this is very important thing you should follow when you are appearing for a AIMS question, AIMS exams. So first of all, have you read this concept? Read the question, understand whether you have read the concept. Yes means, can you exclude two choices? Yes means you then attempt the question. Otherwise, don't waste your time on beating around the bush in this question. So if you have never read this concept, you should not attempt the question at all. That is what needed in AIMS exam to get a topmost rank. So Mrs. Rama, 40 years female, appeared for fibroid uterus by laparoscopic method, was discharged on third post-op day. She presents to hospital on fifth post-op day with a guarding and rigidity. So this question is related to complications of laparoscopic surgery. CT shows diffuse collection inside the abdomen, and radiologist gave a suspicion of bowel leak. During surgery, the metal needle holder was touching the bowel, and the metal needle holder was touched by the monopolar diathermy. What would be the cause of bowel leak which has happened in this case based on the above statement? Can you tell me the answer? The answer for this question is yes. Answer for this question is direct coupling injury. So please don't forget, this is a very important question. You should not forget direct coupling injury. See, there are two types of injuries you get in laparoscopy to the bowel. So if this is a bowel in the abdominal cavity, so this abdominal cavity, if this is a bowel, if we injure this bowel with the diathermy, that will not leak immediately. Please understand, if I injure the bowel with the diathermy, it won't leak during the surgery. We will see this leak only on later time. So like we get it after 3-4 days, like that area gets necrosed and bile leaks. So it comes up after a few days. So no, this is actually in old edition, it was mentioned as indirect coupling. Now they removed that term. In old edition, Bailey, it was like indirect coupling. So in this, the answer is direct coupling only. Please understand the point very clearly. So there are two types of injuries only now mentioned in new Bailey. That is, one is direct coupling injury, another is insulator defect injury. Only two are there in Bailey. So please understand, this is the instrument which is used in the laparoscopy, which is insulated instrument. Okay, this is fully insulated, and only the tip is exposed to the exterior. So only the tip is exposed to the exterior. So when I'm operating, I will be operating some gallbladder or appendix here. By that time, if this insulator is defective here, current will touch the bowel and you won't recognize it and will come to you later. So this is one injury mentioned in Bailey law called as insulator defect injury. Okay, insulator defect injury. Actually, this was very much complicated in 27th edition Bailey. In 28th edition, this is update. Simple, they have made it very simple. So 28th edition update. So it's an insulator defect injury. Okay, this is first injury. This is most commonly seen injury we see in practice due to damaged insulators. We are using the same instrument. No, so sometimes the insulator might have a damage that will touch the bowel and they will come to you with a delayed peritonitis. So this is a very important concept from Bailey and law. So another way is my instrument is 100% perfect. So my instrument is 100% perfect. There is no damage in the instrument, and I'm operating on a gallbladder here. And by mistake, during the surgery time, I am touching please understand, I'm touching a metal needle holder. This is a metal needle holder. So I am touching a metal needle holder. Through this, the metal needle holder, the current touches the bowel. So the bowel gets injured here. So I touched a metal needle holder touched the bowel. So now this is going to transfer the current from here to here. So this is direct coupling injury from New Bailey. So please remember what is there in New Bailey, you remember that. Because Old Bailey, there are so many other injuries also mentioned. All those concepts are removed now. Capacitance coupling, indirect coupling, so many points are removed. There are only two injuries from 28th edition Bailey. Just number one, insulator defect type of injury. Another is direct coupling injury. In both the cases, the bowel gets leaked and the patient comes to you with a delayed peritonitis. So don't forget, I'm again telling you, if you are going to answer for a AIMS question, first thing you should put is, have you read this concept is the first question. If you have read the concept, can you exclude two choices is the second question. Then only you should attend the paper. If you can't exclude two choices, put it in the review. We will come back later if you have time. If you have not read this concept at all, leave it. Don't try to attend it. You'll go for negative marks. So this is very important. 28th edition Bailey updated topic. There are only two types of injuries, insulator defect injury and a direct coupling injury. In a direct coupling injury, I am touching a metal instrument. That metal instrument is in contact with the bowel. Don't forget this question. Second question, Mr. Kumar, 25 years male, operated for mesenteric trauma. Around 400 centimeter of small bowel was removed 1 week back. He came to hospital now with a severe diarrhea, steatorrhea, high acidity. Can you tell me what is this concept related to? This is the diagnosis of short bowel syndrome. Okay, short bowel syndrome. So this is a case of short bowel syndrome. And this question is not related to short bowel syndrome. He was planned for TPN and the cannulation was done via subclavian vein. After 30 days of TPN, patient has fever. So what is a common problem? So this question is related to catheter-related sepsis. The question you should understand, the concept is related to catheter-related sepsis. Have you read this concept? That is the first question you should put. If you have read this concept, then only you should try to exclude two choices. If you are unable to exclude two choices, put it in review. Now answer this question. Catheter-related sepsis is a common cause and commonly happens due to most frequent manipulation. That is absolutely correct statement. Recent method to confirm sepsis is to do sample aspirate from organisms in the central vein as well as peripheral vein. Yes, if they both are same organism, it is catheter-related sepsis. Colony count from the central vein is more than 5 times. It is confirmed. So colony count in the central vein is more than 5 times. It is confirmed. Same catheter can be used after giving antibiotics as per culture sensitivity in case of catheter-related sepsis. So very simple, all of you know, you cannot use the same catheter. This is a very simple answer. So same catheter should not be used. If it is a confirmed catheter-related sepsis, you should change the catheter. So catheter-related sepsis, updated point from Bailey and Loud, 28th edition. Catheter-related sepsis, 28th edition update from Bailey. See, many concepts which are there in 27th edition is completely changed in 28th. So if you're going to stick with the 27th edition and you go to the exam, definitely you're going to make a big mistake. So catheter-related sepsis, this patient comes to you with a fever and pain at catheter site. Pain at catheter site. And on examination, you can see redness of the catheter. But we cannot confirm it is catheter-related sepsis just by inspection. So what is the latest method is, recent method to confirm it is, you have to take central vein sample, blood sample, and peripheral vein sample of blood. If both are same organisms, it is confirmed catheter-related sepsis. Remove the catheter and put a new catheter on opposite side. Remove catheter and put new one on opposite side. So you should not make a mistake in this, because the last year the answer was you put a brush cytology and take a brush cytology from central vein and peripheral. Even that is not there in new edition. It is just a central vein sample and a peripheral vein sample. The same organism, remove the catheter and put a new catheter is the answer for the second question, which is going to ask about catheter-related sepsis. Okay. So now the third concept is a very simple concept. If you have read this, you should answer. Otherwise, you should skip this type of questions. It's about the day case surgery. Day case surgery is a surgery in which the patient is admitted and discharged within 12 hours. That is what the definition says. So day care or same day surgery is a patient admitted at 8 o'clock and discharged at 8 p.m. 8 a.m. to 8 p.m. That is a day care surgery we do in our practice. So don't forget, let us see which of the following factor given below will make him unfit for a day care surgery. So in other words, what are the contraindications of day care surgery? So they're asking which is a contraindication of day care surgery. So BMI up to 40 we can do. So number one, it is not a contraindication. Surgery has expected time of less than 2 hours you can do. So the patient will go home by 8 p.m. No, he should be available within 1 hour travel. Within 1 hour travel from the hospital, from the place where he operated. He should not come after 2 hours. Journey time from the home should be 2 hours is long. It is only 1 hour. No upper time of the limit of age can be done at any age. Please don't forget there is no upper age limit. Can be done at any age. That is also true. So let us see the types of ambulatory surgery. Ambulatory surgery means surgery done and patient mobilized fast. The outpatient surgery not admitted in the ward. Surgery not requiring full theater facilities is called as sterile facilities is called as procedure room surgery. And this is the question on daycare surgery. So which is done in 12 hours. Overnight surgery is 23 hours. Comes to the morning 8 a.m. and tomorrow 7 a.m. he gets discharged. Short stay surgery is 3 days. Short stay 3 days. Overnight is 1 day. Half day is day case. So this is the selection criteria for day case surgery. It is actually from anesthesia in Bailey. Bailey has this point in anesthesia chapter. So medical use physiological rather than chronological age. So there is physiological age is important. There is no use of chronological age. BMI less than 40 is not a contraindication. So provided BMI is under 40, no issue, nothing to worry. And 24 hours, a responsible adult must be available. Home conditions must be good for a daycare surgery. Surgical operation should be only up to 2 hours. Please don't forget. And patient should be able to eat and drink after the surgery. In a 12-hour surgery, you should be able to eat and drink. So what are the places where we need not cancel? And the BP is up to 180 to 110, does not need to cancel. HbA1c. So then means what? If BP is more than 180, I will cancel. HbA1c more than 8.5, I will cancel. Epilepsy is not a contraindication, but you should not avoid tablets. BMI up to BMI more than 40 is a contraindication. Travel time to the hospital is less than 1 hour. This is very important, not 2 hours. Surgery time should be 2 hours and travel time should be within 1 hour. So this is a simple question made by me just to give a clarity on daycare surgery. So that is one common question. If a daycare surgery patient goes home within 12 hours, what is the most common cause for readmission? Most common complication. What is the most common complication of daycare surgery? Can you tell me? Yes, anybody? What is the most common complication of daycare surgery? Nausea and vomiting. Okay, nausea and vomiting is one of the most common causes to retain the patient for 12 hours. To retain the patient for still more hours. Okay, more than 12 hours. I am retaining the patient in my hospital because patient is having nausea and vomiting. So I need to discharge within 12 hours, but I'm unable to discharge the patient because patient is having nausea and vomiting. Therefore, what is the most common cause to retain the patient in the hospital itself is daycare. In a daycare surgeries, nausea and vomiting. What is the most common indication for readmission? The readmission. Patient went home. I'm calling him back. Patient is coming himself back. The dressing we have made is now bleeding. Bleeding is a common cause of readmission. So don't forget these 2 points. Most common complication of day case is nausea and vomiting. Most common cause of readmission is bleeding. Don't forget these 2 questions for your exam. Okay. So when are the places where it is contraindicated? BP more than 180, HbA1c more than 8.5, BMI more than 40, travel time more than 1 hour, and surgery time more than 2 hours are all contraindications for a day case surgery. We have to cancel the day case and we should either keep them overnight stay for 23 hours or we should keep them even for 1 or 2 days. So the concept related next is Mr. Gupta, 30 years male, faced a massive road traffic accident and was admitted for multiple fractures. He was planned for damage control surgery. So the concept is related to damage control surgery. Damage control surgery is an emergency surgery done in trauma to decrease deadly triad of trauma. What is deadly triad of trauma? Hypothermia, acidosis, coagulopathy. Hypothermia, acidosis, coagulopathy is a triple deadly triad of trauma we should follow. Deadly triad of trauma is hypothermia, acidosis, coagulopathy. To decrease this hypothermia, acidosis, and coagulopathy, I will do a simple surgery which will not be a complicated one. Can you tell me which is the answer for this? BP less than 70, acidosis due to lactate level more than 5, blood transfusion more than 15 units, and injury severity score more than 36. This is injury severity score More than 36 is answer, not this D. Okay, answer is D. So criteria for damage control surgery are hypothermia, acidosis, coagulopathy. Lactate level more than 5 millimoles is a very important value, because if the lactate level is less than 2 millimoles per liter, I can do a definitive surgery. Definite surgery can be done if it is less than 2 millimoles. I'll go for a damage control surgery because the value is more than 5 millimoles. BP less than 70, transfusion units 15 units, injury severity score is more than 36. Please don't forget what is this. And it's a favorite topic of national board exams. Damage control surgery is made up of stage 1. Select the patient. Select which case is suitable for damage control surgery. That is stage 1. Stage 2. Shift the patient to emergency OT. In an emergency OT, I will not do a definitive anastomosis and all. I will only do packing, simple procedures. As simple procedures I will do. I don't do no anastomosis in this procedure. In a stage 2 case, no abdominal closure also will be done in this stage 2. Just you go to emergency OT and do a packing for the bleeding, or exteriorize the bowel in a case of any peritonitis, packing or exteriorization like stoma. That is what we do in a stage 2 cases. Stage 3 cases. Stage 3 cases, patient are shifted back to SICU for 24 to 48 hours. Stage 4, what will you do in this patient? Stage 4, reshift to OT. Reshift to elective OT. Now I'm going to have all the team members like cardiothoracic surgeon, neurosurgeon, everyone will be there in the theater. Everyone will be there to monitor the case and look for any other injuries, and definitive surgery will be done here. And stage 5 is the place where we close the wound. Like laparotomy, if it is done, close the wound now. Previously in a stage 2, I have not closed. I am now only going to close the wound. So don't forget, laparotomy, abdominal closure is done in stage 5. So this is a classical question on damage control surgery. Never attempt the question if you don't know the concept. This is what I'm telling you always. For AIIMS exam, the golden rule is never attempt the choice if you don't know that concept at all. There will be definitely some 20 concepts which you might not know. Of the 200 questions, 20 to 25 concepts, nobody will know. Whoever appearing for the exam will not know. Don't try to attend those questions in a fluke. Definitely they'll go for negative mark. If you don't know any concept, just leave it. Nobody will know that concept. Regarding diagnostic peritoneal lavage and fast. So this is the concept related to diagnostic peritoneal lavage and fast. So diagnostic peritoneal lavage is an invasive procedure. Yes, if you are going for a phases, it is from Sabiston, but I will tell you, phases is from Sabiston. They won't ask you questions from Sabiston usually. Phase 1, 2, 3 is from Sabiston. Only Bailey says stages. So you go for this. Phase 1 is emergency OT. Phase 2 is SICU. Phase 3 is elective OT. That's all. This is phases from Sabiston. So as you all know, your UG book is Bailey and Love. So you should follow stages. Sometimes they may ask you, but please understand there is a difference between stage and phase. Sabiston discusses in phases. Bailey discusses in stages. So answer this question, urine dipstick can be used in the absence of lab in the night time. Yes. In penetrating trauma, more than 10,000 RBC is positive. Fast cannot detect 100 ml of fluid in the peritoneal cavity. Retroperitoneal injuries cannot be detected by EFAST, but can be detected by DPL. So can you tell me what is the answer for this question? What is the answer for this question? Answer is retroperitoneal injuries cannot be detected by EFAST as well as by DPL. For a laparoscopic surgery only, this discussion is going on. Actually, if you see, provided that the BMI is under 40, this alone is not a contraindication. This alone is given from Bailey and Love. So, but if you go for other books like Sabiston, Swartz, they say for a laparoscopic surgery, BMI up to 37 is a cutoff. And for open surgery, BMI 39 is a cutoff. But for AIIMS exam, please read this table. This table only they'll ask you. This table only they will select for a INICET PG exams. Okay. If there are some SS aspirants, don't get into this, because this is for NEET PG exams. So DPL is positive in blunt trauma in the following cases. When will you say DPL is positive? More than 1 lakh RBC per ml, that is positive. More than 500 WBC per ml, it is positive. 10 ml frank blood is coming out. On putting a tube, 10 ml frank blood comes as positive. More than 19 international units amylase is positive. Bile is present is positive. Food is present is positive. All these are said to be DPL positive. And DPL is a peritoneal lavage, not useful for retroperitoneal injuries. Not useful in retroperitoneal injuries. So this is for blunt trauma. These values are 1/10 thin penetrating trauma. That is a line from Bailey and Love. 1/10, for example, 10,000 RBC, 50 WBC, like that we can put, but they have not mentioned the values and all. Just mentioned as 1/10 is penetrating trauma. Just remember 1/10 is penetrating trauma. So the answer here is retroperitoneal injuries cannot be directed both by EFAST as well as DPL. So the next question is related to retroperitoneal hematoma. A patient had a blunt trauma and presented with a retroperitoneal hematoma. Which of the injuries shown in the image you must never try to operate? Please understand the image shown here. This is zone 1. These are zone 2. Okay, zone 1, zone 2. Zone 1 is zone involving aorta and IVC. Zone 2 is renal hematomas. Zone 3 is pelvic hematoma. This is zone 3, pelvic hematoma, injury of pelvic blood vessels. Okay, so this point you should not forget. Pelvic blood vessels. And zone 4 is, what is zone 4? Zone 4 is retrohepatic IVC. Retrohepatic IVC is zone 4. Yes, if you go for international units, it is 19 international units. Or if you can go for other many units are there. From substance, this is 19, more than 19 international units of amylase in the fluid. In Bailey, there is no amylase level given. Just they mentioned amylase positive, that's all. So aorta, IVC, renal, pelvic, and retrohepatic IVC. Which zone you should never operate? Can you tell me the zone which should not be operated is? Zone 1. Zone 1 needs immediate surgery by Mattox maneuver for aorta. Mattox maneuver is done for aorta reaching, and Kettle-Brash maneuver for IVC reaching. So immediate surgery. Zone 2 can be treated by non-operative management in 90%. 10% may need surgery. Zone 3 should never operate. Okay, please don't ever think of opening, because once you open, the hematoma will start bleeding. So just pelvic binder is enough. Pelvic binder is enough for zone 3. And zone 4 also we need to operate. Zone 4 is a retrohepatic IVC, surgery done. Okay, these are the very important topics. So the answer here not to be operated is zone 3, we will never touch. Okay. Mr. Kunal Gupta, 50 years old male, severe beetle nut tumor presents with a painless ulcer. So it's a question on oral cancer, swelling in the left side of the neck. So oral cancer, neck node. On examination, there is an ulcer of 3 into 2 centimeter. Swelling is solitary and found to be a node 3 into 2 centimeter in size. On evaluation, this patient, which of the following statement is false? So there is a node is there, ulcer is there in the node, in the mouth. So what should be done first? In the protocol in a oral cancer is always tissue diagnosis should be done after MRI, because MRI, if I do tissue diagnosis first, that hematoma or bleeding which will cause the damage of the anatomy. So MRI is done before biopsy. Okay, therefore, what is done first means MRI is done after tissue biopsy is wrong. So we should only do MRI first. In case of bone involvement, MRI is the investigation of choice for T staging and N staging. But if you want to know bone involvement, CECT is the investigation of choice for bone involvement. And lymph nodes, I told you there is a lymph node in the neck. Can we do biopsy? Lymph node biopsy can be done. Not biopsy, we usually do an FNAC. FNAC will be done for a lymph node. So in case of bone invasion, CT scan is best. Tissue diagnosis with the edge biopsy. Wedge biopsy is what called in Bailey as incisional biopsy. Ultrasound guided FNAC can be done, and there is no evidence of tumor seedling in the tract. So people say we can do FNAC if you want for a neck node also. So the answer here is, this is 28th edition updated point. Please don't forget FNAC of the node can be done. Mrs. Kumari, 25-year female, presents with thyroid swelling with the complaints of diarrhea. On evaluation, she gives her mother expired due to some cancer inside the abdomen. Now on evaluation, FNAC showed here in the picture. What is this FNAC finding? So this is a pathology question plus surgery question. Amyloid stroma you are seeing here. And the girl is giving history of mother died of some cancer in the abdomen. It is nothing but pheochromocytoma. What is the true statement about medullary cancer? So this is medullary cancer in a men 2A syndrome. Men 2A, men 2B syndrome. In these two syndromes, there is a mutation called as ret oncogene mutation. So ret oncogene mutation in men 2A, men 2B, the first common cancer 100% is medullary thyroid cancer. And 40% of them will have pheochromocytoma. 40% of them will have pheochromocytoma, 100% they have medullary thyroid cancer. Therefore, men 2A should undergo before 5 years prophylactic thyroidectomy. Prophylactic total thyroidectomy should be done in before 5 years in men 2A and before 1 year in prophylactic total thyroidectomy in men 2B. Before 1 year in 2B and 2A, it should be before 5 years. Don't forget this. So medullary cancer has an FNAC showing you amyloid stroma, and the tumor marker of medullary cancer is calcitonin and CEA. These are the two tumor markers, CEA and calcitonin. And please don't forget, medullary cancer produces serotonin that causes this diarrhea. So associated with the MEN1 syndrome is wrong. Most common site for metastasis is liver, not lungs. Lymph node involvement is seen, and it is not TSH dependent. TSH dependent cancer is papillary cancer. Papillary cancer is TSH dependent. So the answer here is C. Very good. It's medullary is correct. So your name is in. Could not understand. Though I could read Hindi, I could not understand what you're writing. Nitya, something. I don't know. I could not read fully. Nitya. That's fine. Okay, nice. So 45 years old obese premenopausal woman, Mrs. Rani, presents to your breast clinic on routine mammography. You found out she's having a 5x4 centimeter breast lesion. So 5x4 centimeter. Can you tell me what is this? 5x4. So T1 is less than 2. T2 is 2 to 5. So this is T2 lesion. On examination, she had multiple axillary nodes. So multiple axillary nodes is N to A. Multiple axillary nodes fixed to each other is N to A. TrueCut shows lobular cancer of the breast. Please don't forget, that's an important point. Lobular cancer of the breast. So ER negative, PR negative, HER2 positive. HER2 is positive. So which of the following is wrong in this case? So this is about the lobular cancer. Please remember, you should have read about lobular cancer before attending this choice. Let me tell you 5 points from lobular cancer of breast. Lobular cancer is associated with E-cadherin mutation, which is causing cancer stomach. So CS stomach plus lobular cancer is associated with this, and it is bilateral. It is bilateral in all the cases, bilateral in all patients. Therefore, you should do bilateral biopsy. Even if you don't have a lesion on the other side, you should take a biopsy. And biopsy shows Indian file pattern. This is a picture showing you Indian file pattern on biopsy. Please don't forget, it's an Indian file pattern shown on biopsy. It is bilateral in all patients. Bilateral biopsy should be done. So please don't forget. Okay. Anyhow, I have spelled you correctly. Okay. So this is an Indian file pattern. Bilateral biopsy is done bilateral in all patients. So it is associated with E-cadherin mutation. And lobular cancer always needs bilateral MRM. Please remember, it should need bilateral MRM. And don't forget, bilateral MRM is needed for those cases. And according to this question, ER-PR negative means no hormone receptor needed, only HER2 positive. So I will give only trastuzumab. So opposite breast must be biopsy, as cancer can by FNAC under MRI guidance. True. Tamoxifen in the post-op, how can I give? ER negative, so no use of tamoxifen. Breast conservative surgery cannot be done. Okay, breast conservative surgery is contraindicated. Yes, that is correct. Breast conservative surgery should not be done. You should only do a MRM. Ideal treatment will be bilateral MRM and trastuzumab therapy. So answer is D here. So that's correct answer here is yes. Indian file pattern is classical finding you are seeing in this image. It's a classical MCQ. Don't forget. The answer for this question is breast conservative surgery is contraindicated is true. And which is the wrong answer is only B is the wrong answer here for this 9th question. Okay. Mr. Ramu, manic depressive illness. What is this concept related to? Multiple renal stones, pancreatic stones. He was evaluated for left side ultrasound neck. Showed a nodule in the left inferior parathyroid. System scan showed another nodule in the upper part of the neck. And we are planning to do surgery, which is a false statement. So this question is related to parathyroid adenoma. Parathyroid adenoma. So please understand the parathyroid adenoma related protocol. parathyroid adenoma protocol. Just I'm telling you the protocol from Bailey and Lowe. So parathyroid adenoma patient comes to you with the bone stones, abdominal groans, and psychic moans. And when I do, parathyroid hormone is elevated, calcium is elevated, phosphate is decreased in a solitary adenoma, and increased alkaline phosphatase will be there. This is a clue you are having a parathyroid adenoma. Now, next I will do two investigations. Ultrasound of the neck, and I will also do systemic B scan. Systemic B scan with the technetium 99M subtraction is needed because Hurthle cell adenoma also will catch up this thing. Okay, so Hurthle cell adenoma will also catch up this. So you should not forget this point for your exam. Okay, so Hurthle cell adenoma will catch up this case, systemic B scan and ultrasound neck. So Hurthle cell adenoma, to subtract Hurthle cell adenoma, I need to go for a systemic B scan along with the ultrasound neck. So don't forget these 2 points, systemic B scan and ultrasound neck. These 2 points don't forget. Systemic B scan and ultrasound neck both are showing the same finding or same finding. For example, there is a nodule in the left side, means I will go for MIP. MIP means minimally invasive parathyroidectomy. Minimally invasive parathyroidectomy in such case. If they are showing different finding, what will I do? If they are showing different finding, I should go for a 4-dimensional CT scan. Different finding means one is showing me nodule here, this is showing here, means I should go for a 4-dimensional CT scan. And if there are different finding on a 4-dimensional CT scan also, I should go for a bilateral cervical exploration, means I should remove all the 4 parathyroid glands. So there are 2 surgeries done. Single gland enlarged means minimally invasive parathyroidectomy. If bilaterally glands are enlarged means we have to go for removal of all 4 gland removal. So this is very important. This is very important. You should not forget. In this concept, so minimally invasive parathyroidectomy, after doing the involved parathyroid, I should do a Miami criteria. See, all these questions you can understand only if you have gone through the app. If you have gone through the app, I have discussed about all these concepts for half an hour. Please go through the app if you have a doubt on these concepts. So these are all highly expected AIMS question. You should not have any doubt. So Miami criteria is after surgery of parathyroid adenoma, I should measure parathyroid hormone level. Parathyroid hormone level should decrease 50% of baseline. If decreases, problem solved. If not decreases means you should do bilateral cervical exploration. It's an extraordinary point you should not forget. It should do bilateral cervical exploration if it is not decreasing. So don't forget the answer. Now let us see the question. So we are planning to do surgery, which is false statement from the given below. False positive MIB scan is associated with Hurthle cell adenoma. Hence, I am doing technetium 99M subtraction image is true. Discordancy in images further evaluated by CT scan. Yes. Minimally invasive parathyroidectomy with a small incision, 3 centimeters is enough for this patient. Please see the patient. He was evaluated for ultrasound. There is a nodule in the left inferior parathyroid gland. Systemic showed another nodule in the upper. So it is a discordant image. So I cannot go with the minimally invasive parathyroidectomy. And no further evaluation needed in this case is absolutely wrong. So this is absolutely wrong statement. Bilateral exploration and removal of all 4 glands and leaving 1 gland in the neck itself is a preferable method for this case. So we should not do this because this is a discordant image. So this discordant images, we should only go for this. Don't do minimally invasive parathyroidectomy. Go for bilateral neck exploration. So don't forget this point. Very important. So the Miami criteria is a very commonly asked MCQ. Miami criteria says if the value decreases to less than 50% in 10 minutes, you have to go for this. Okay. Mr. Solomon, a Dutch fleet is a gluten used to induce autoemesis. One day while he autoemated, Professor Boerhaave noted he is having a severe pain in the chest and breathlessness. He was evaluated. So this is related to Boerhaave syndrome. So please remember, in a Boerhaave syndrome, there may be a perforation in the thoracic esophagus or in the abdominal part of esophagus. So they can have peritonitis also sometimes. Most of the time they have macular striae. So macular striae is very common. Vomiting, chest pain, subcutaneous emphysema. And immediately I should do a CT with the oral contrast. And if the patient is seen yearly, we should open and do repair of the tear The patient is seen very late, we have to put a T-tube drainage. So there will be severe rigidity in the abdomen. Yes, true. CT is required for guidance. T-tube drainage of the esophagus with the feeding jejunostomy is done in cases of late presentations with severe contamination is true. So selected patients can be treated by non-operative management is absolutely wrong. Bohr syndrome, there is no such word known as non-operative. Bohr syndrome needs always surgery. Please don't forget this point. And what are the points related to perforation of esophagus? Factors that favor non-surgical management are small septic load, minimal cardiovascular upset, perforation confined to mediastinum, perforation done by endoscopy, perforation in cervical esophagus. Only in these 5 cases, we can go for non-operative management. But you see, Bohr syndrome, always surgical repair. Septic shock, pleura breached, perforation of abdominal esophagus, large septic load. These patients will need emergency surgery. Don't delay, okay? So all of you know about dumping syndrome. There is a question on false statement regarding dumping syndrome after peptic ulcer surgery. So dumping syndrome is following a rapid emptying of food from the stomach to the duodenum. So if there is a food here, it fastly goes into jejunum. That is a rapid gastric emptying. So rapid gastric emptying is a common feature of early and late dumping is true. Early dumping is seen even in high selective vagotomies. Please understand, we have many surgeries for peptic ulcer like high selective vagotomy, truncal vagotomy with GJ, truncal vagotomy with antrectomy. All these surgeries are done for peptic ulcer disease. So in all these surgeries, you can get a dumping syndrome. It is very common in Billroth 2 type of reconstruction. Billroth 2 reconstruction is most common to develop dumping syndrome. This is Billroth 2 surgery. So duodenum stump is closed and this is GJ. So this is gastrojejunostomy. So most common in Billroth 2 and least common in high selective vagotomy. So dumping syndrome is least common in high selective vagotomy, most common in Billroth 2. So therefore, please remember here, early dumping is seen in high selective vagotomy also. Very rarely it can be seen. Somatostatin is useful for diarrhea, which develops in dumping syndrome. Please remember, dumping syndrome is characterized by diarrhea. Dumping syndrome is cured by somatostatin, except diarrhea. Diarrhea cannot be cured by somatostatin. This is a direct line from Bailey and Lowe. Patients who are having so much of dumping syndrome, revisional procedure of choices, antrectomy plus Roux-en-Y reconstruction. This is also correct from Bailey and Lowe. How to prevent dumping syndrome? Please understand this question commonly asked. How to prevent dumping syndrome? High fat and protein diet, the reduced carbohydrate diet. Small regular meals are advised. Octreotide or other long-acting analogs may be helpful, but not prevents diarrhea. Please remember, they are not preventing diarrhea. Maybe little helpful. So revisional surgery with antrectomy and RYGJ is done in the procedure of choice. Octreotide is very effective for late dumping syndrome, but not helpful for diarrhea. So just remember this paragraph from Bailey and Lowe. High yield topic for your exams, dumping syndrome also. Obesity surgery. Now you all know very well, obesity surgery has become a part of surgical specialty. Obesity surgery mortality risk score predict the prognosis of the patient after surgery. Given 1 point for the following factors except. So age above 45, give 1 point. BMI above 50, 1 point. It is not for female gender, it is for male gender, 1 point. And hypertension, 1 point. So totally 5 points are there. So age, BMI, male, hypertension, increased risk of DVT. Each one you give 1 point. So if there are 5 points, the risk of mortality is very high. 1 point mortality risk is low. So depending upon the points we give 1 point for each. Increased points as increased risk. Obstructive sleep apnea is a risk for anastomotic leak. Uncontrolled diabetes is also a risk factor for obesity surgery. Mortality risk score, don't forget. So they have to understand this point. So this question is an image-based question. Can tell me, Mrs. Kamala, 50 years, female with a history of OCP, comes to you. So many times when you see the history of OCP, people think it is adenoma. Please remember, adenoma, FNH, both of them have history of OCP. But the catch point here is this image. So this image shows central stellate scar. What is this? Central stellate scar is seen in FNH. So please don't forget the answer is FNH. Focal nodular hyperplasia has a central scar. Central stellate scar. It is not going to get converted to malignancy. So no treatment needed for FNH. The best answer here from the picture from liver, don't forget FNH. So you should understand the concept, as I told you. Mrs. Rani, who had laparoscopic cholecystectomy 2 days back, is now presenting with the right hypochondrial pain and fever. Urgent ultrasound abdomen revealed collection of 10 centimeter in the right hypochondrium. Urgent PCD done and the patient is observed in the ward. Which of the following is not a part of further management? HIDA scan is helpful to confirm the leak or obstruction. ERCP, if available, is the best to diagnose the leak. MRCP may also help us to determine the level of injury. And CECD abdomen is always done post-surgery as a part of follow-up. Please remember, as a part of follow-up, we don't do CT scan in any cases. This is not a part of follow-up in all cases. So answer is D here. So please understand, if a patient comes to you with a bile leak complains of fever and pain. A patient has bile leak means you have complaints of fever and pain. What is the first done investigation? Always ultrasound, which will show you a 10 centimeter collection. Now I want to confirm bile leak means all the following investigations are helpful. Like to confirm leak, we can use any investigation like HIDA scan. Yes, it will show you leak. MRCP will show you leak. CT will show you leak. But to confirm the site of leak, the best is ERCP. ERCP is the best to confirm the site of leak, and that we have a Strasbourg classification. Favorite AIMS question, Strasbourg classification. Please go through that. Strasbourg classification is a question which you should never forget for your exam. So the answer here is CT abdomen is not a part of routine. If we do when we have a doubt, first done is ultrasound, and to confirm the leak, we have many investigations, but to confirm the site of leak, it is ERCP. So this is a Strasbourg classification, favorite question of your exams. Type A is cystic duct leak. Please go through this. Type B is aberrant duct clipped. Type C is aberrant duct cut. D is lateral injury. And E is circumferential injury. Okay, circumferential injury. Please don't forget these injuries shown from Bailey and Lowe for your exams. Okay, Strasbourg. Mr. Somo, 25 years, alcoholic male, was admitted in ICU for severe acute pancreatitis. CT abdomen was taken on 4th day of admission is shown here. Which of the following is not a part of management now? So this is the case of a necrotizing pancreatitis. You can see a pancreatitis with an air means what? It is necrotizing pancreatitis. Patient is now infected. Percutaneous drainage is the first thing. Percutaneous drainage of infective fluid must be done by a percutaneous tube. If sepsis worsens, you can even do necrosectomy. If head is involved, retroperitoneal flank approach is advised. No, if this tail is involved, we can go for retroperitoneal approach if the tail is involved. Bigger advised continuous lavage of lesser sac. Bigger advised continuous lavage of lesser sac. So please understand the concept of Panther trial. Latest update from Bailey and Lowe. Panther trial for pancreatic necrosis. What they say? This is from Bailey and Lowe, new update. Patient comes to you with a pancreatic necrosis. What should I do first? Step up approach. This approach is called as step up approach. First, you do a percutaneous drainage. For example, this a patient comes to you with a pancreatic necrosis. Just call the radiologist, ask them to put a tube like this percutaneously. Then second approach is video assisted retroperitoneal debridement. So for example, if the necrosis is in the tail, body and tail, I can go put a nephroscope and go by a small hole and remove it. If it is in the head, I can go by minimally invasive necrosectomy using laparoscope for head. If the patient is still not improving, then you can go for the third step, open necrosectomy. You put a big rooftop incision, remove all the necrosis, and keep a drain like this inside, another drain like this in this side. What I will do, I will wash through this fluid, and that will come out like this. This is called as Beager procedure. Beager's advice. This is not Beager's procedure. Beager's advised continuous lavage. So this is called as Beager's continuous lavage procedure. So please don't forget, this is pancreatic necrosis style. First step is PCD. Second, ward or minimally invasive necrosectomy. And finally, we go for the open surgery. We step up the procedure. Go by step. That is a treatment of pancreatic necrosis. So I have mentioned here. So blunt dissection is preferable to sharp dissection, because if I do a blunt dissection, I can injure the vessels running behind the pancreas. A rigid laparoscope is inserted in the peripancreatic area through a retroperitoneal approach, and vigorous irrigation and suction is combined with a gradual nibbling of the necrotic debris. So please remember, head means we have to go for a laparoscopy. Retroperitoneal means we have to go by a body and tail means we go by a retroperitoneal approach. Okay. Mr. Mishra, 40 years male, presented to us with a stone in the renal pelvis of size 2.5 centimeter. Okay, 2.5 centimeter stone like this. So stagon stone. The stone is planned by a PCNL. Surgery done successfully. Regarding PCNL procedure and complications, what is a wrong statement? Can you tell me what is a wrong statement? After conclusion of the procedure, a nephrostomy tube is kept in the kidney for 24 years. After completing this procedure, keep a tube temporarily here. This is ideal procedure for a patient who are having diverticulum. This is diverticulum, stones in the diverticulum. Yes. Hemorrhage from the renal vessels. If by chance, if I injure the renal vessels, small vessels, not the main, we won't injure the renal artery main, but small renal vessels which are coming, no, they might be punctured, which can be treated by open surgery is wrong. We can be treating it by angioembolization. Yes, injury to colon can happen in a subcostal approach. So this is a kidney. So this can be approached by subcostal approach or a transcostal approach. Transcostal approach, I can injure the pleura or lungs. Subcostal approach, I will injure the colon or duodenum. So please don't forget to read about PCNL, percutaneous nephrolithotomy. It's a favorite topic, and there are so many updates in New Bailey and Love. I want you to just know the scopes I'm going to show you now. So this is a flexible, this is a first picture is a flexible ureteroscope. What is the use of this? Flexible ureteroscope is to remove the stones in the ureter. And this is rigid ureteroscope. Stenting into the ureter can be done with the help of rigid ureteroscope. This is a picture showing you cystoscopes. All these cystoscopes are used in TORP procedure. Cystoscopes are used in TORP procedure. So we can have different type of sheets and all available. So with this cystoscope, I can remove the stent. Remove the stent can be done with the help of cystoscope. Putting the stent is by means of rigid ureteroscope. So with the help of rigid ureteroscope, you pass the stent. You remove the stent with the cystoscope itself. No need of anything else. So this is a nephroscope used for PCNL. In this picture, if you see, there is an eye channel here. This is one eye channel which you see. This is eye channel here, and this is operative channel here. There are two holes. So in one scope, there are two ways. One is to see, another is to use the instruments. Nephroscope. Mr. Ganeshan underwent TORP in a urology department in a government hospital. So in a government hospital, probably he was undergone using a distilled water. Distilled water. Identify the correct match. Confusional status. What is the cause of confusional status? Is due to water intoxication and hyponatremia. It is due to water intoxication and dilutional hyponatremia. Please don't forget this point. Retrograde ejaculation. Retrograde ejaculation is due to injury of internal urethral sphincter. Internal urethral sphincter injury causing retrograde ejaculation. Okay, that will cause retrograde ejaculation. Incontinency is because of external urethral sphincter injury. Okay, external urethral sphincter injury is very dangerous. Yearly rigors following surgery is due to bacterial sepsis. So the answer here is 1F, 2E, 3D, and 4A. So better answer is A here. Please go with the A in 18th question. So please understand the TORP procedure. This is a urethra. This is prostate, which is enlarged like this. This is an enlarged prostate. And this is internal urethral sphincter, which is under involuntary control. And this is external urethral sphincter. When I'm doing TORP and I'm going to remove all these tissues little by little, I should stop my resection at this point. What is this? This is called as verumentanum. You should stop your dissection at verumentanum and don't go below verumentanum. If you go below verumentanum, you will injure the external urethral sphincter, which is a dangerous complication called as incontinency. But if you go in this internal urethral sphincter, this is the most commonly injured complication. That is internal urethral sphincter. Nothing to worry. The old man will have a retrograde ejaculation. That's all. So this is very important. Two complications you should not forget. And when I'm doing distilled water irrigation, the water will enter the blood and will cause dilutional hyponatremia and confusion. Okay. False statement regarding varicose veins management by recent advance. So please don't forget, gold standard of varicose vein is now endovenous ablations, either by using laser or RFA. So we have two methods to ablate the veins. That is, one by using a laser probe or by using a RFA. So endovenous laser, no, laser can ablate any size of veins with a low rate of recanalization. So any size of vein can be ablated by endovenous laser ablation. RFA is best for tortuous veins and perforators. No, it is absolutely wrong. Tortuous veins and perforators, laser is correct. See, laser is one energy device, RFA is another energy device. In RFA, there is a heat happening. Okay, don't forget this. And RFA is costly than Evlar, true. Tessari method is foam sclerotherapy is also true. So the answer, this table, don't forget, endovenous laser ablation can ablate any size vein, can treat perforators and cheaper laser fibers. Whereas RFA, disadvantages are cannot pass via tortuous vein, cannot treat perforators and costly. And laser is having a standardized protocol of push and pull is not there. Disadvantage is every patient we have to change the laser setting and we need the help of some third person. Here in an RFA, set standard protocol is available, no need of anybody else. Even a first year postgraduate can do that easily. So less procedure time, no laser safety protocol needed, reduced pain. So RFA is the latest energy device used for treatment. But the only problem is dilated tortuous vein, difficult to ablate the veins using RFA. This is a picture-based question from Bailey and Lowe. You create foam using this foam sclerotherapy. Okay, foam sclerotherapy is very important. So now you are seeing the last question for among the 20 questions. We are having 4 images of flaps. Please don't forget, these are all called as random pattern flap classification. These are called as random pattern, means there is no named blood vessel. No named blood vessel available. We just use the leash of blood vessels. Can you tell me what is the name of each flap? First flap is it's also called as, this is rectangular transposition flap. So this is a transposition flap, rectangular transposition flap called as rhomboidal flap. Rhomboidal flap is a type of transposition. There is a defect in this place, like in a pilonidal sinus, and I have shifted this to this place. Can you see? This is rhomboidal flap. It's a transposition flap. And B is a bipedical flap. B is a bipedical flap. So when there is a damage of lower eyelid, I can bring a upper eyelid to down like a bipedical, also called as bucket handle flap. All pictures are from Bailey only. And this is another flap where there is rectangular transposition flap. So this first picture is rhomboidal flap, is also called as Limburg flap. So this is a typical rectangular transposition flap. Rectangular transposition flap. You can see the rectangularly we are shifting here. So first picture is Limburg or rhomboidal. Second picture is bipedical. This is rotation, rectangular transposition. Semicircular transposition is also there. Many types of flaps are there. The last one is a flap which is shifted for a nose injury. For a nose injury, we have done a bilobe flap. Bilobe flap. So please don't forget the flaps. Limburg flap, bucket handle flap, transposition flap, bilobe flap is a correct answer of these questions. So see the images. This is a classical rhomboidal Limburg flap which is used for pilonidal sinus. It's a type. It's another type of transposition flap, but it is rhomboidal in stature. And this is a bilobed flap. Okay, bilobed flap. And this is bucket handle flap. Don't forget all these various flaps for your exams. So this is just a fast review of the 20 questions. We'll be having a video question on INICET video-based discussion questions. I have given 20 questions for the discussion. So you're having INICET mock exam with a video discussion this week. So you are having this exam this week. Please appear for that exam. And we have done all the 200 questions. We have done a video discussion. So here is the time you should know what mistake you should avoid in appearing for a INICET exam. So definitely with the help of DocTutorials Q Bank and the DocTutorial materials, you are going to crack a top rank. So all the best. Any doubts if you have related to the questions we had, please post me. Any questions you have doubts? So this completes the discussion. So any doubts, please tell me. So I have touched, if you see this 20 questions, I have touched all the system, right? From general surgery, trauma, thyroid, breast, everywhere I touched 111 questions so that I can finish up 20 questions, right? From GIT, urology, specialty chapters, every topic I have made some questions. So hope you had a clarity on those things. Please go through the topics which I discussed. You can go through the same content in the app also. Thank you so much. Thank you so much for the discussion and active participation by some of you. So if you have any doubts, you can post in this chat itself. I will answer the queries later. Okay.